conversation around targeting patients, particularly those that are complex and difficult. And these two presentations will be very much aligned with each other, and then our panel as well. Dr. Ann Lindsay and Liz Helms will comment on this. Judy Hibbard could not be with us today. She's got an upper respiratory. She's fine, nothing serious. So I will be making her presentation. I won't do it nearly as coherently as she would if she were here, but I'm pretty familiar with her work. She and Ms. Helms are actually on the External Advisory Committee to a P. Corey grant that I'll be talking about that Hector and I are involved in. So in a way, these are companion pieces. Judy's work, as you will see, has established quite a solid empirical base of evidence that the development of this patient activation measure. Let me pause here a minute and ask, how many of you here today are using the PAM, patient activation measure? 1, 2, just 3 or 4. Okay, we might want to talk about that as we get into this. So Judy is Professor Emeritus now at Oregon Health Sciences Center, continues her work in this area. This is essentially what we'll talk about and really get to the outcomes as well. So this is the definition. An activated patient is one that has the knowledge, the skills, the motivation, etc., to manage their health. And again, demographics tend to account for only about 5 to 6% of the PAM score variation. So a lot of the rest of it is open for our influence. So she has done her program now for about the last 5 or 6 years, and it's been found to be a good predictor of most health behaviors, many clinical outcomes, trajectories over time, so we'll be looking at some over time analysis, and also costs. And that's true controlling for a variety of demographic variables that might be counterfactuals to the findings, and health status as well. And so here's the activation measure. It's 13 items. It's been found to be highly reliable. Patients complete these easily. Hector and I are using these in a study that I'll be talking about in a minute. I'm not going to go over each of these in the interest of time, but just to highlight a few. For example, for the first one there, when all is said and done, I am the person who is responsible for taking care of my health. And these are all disagree strongly to agree strongly. Number 5, I am confident that I can tell a doctor concerns I have even when he or she does not ask. Number 10, I am confident that I can maintain lifestyle changes like eating right and exercising even during times of stress. And then there's 3 others as well. You can chunk these into 4 groups as you see here, and these are empirical estimates over time in terms of the number of patients that fall into each of these. So level 1 is the low. They're really overwhelmed, they're disengaged, they just can't do it. Life is too complex, taking too much of my time. I've got many other priorities in my life. Level 2, about 10 to 20% there, becoming aware, still struggling. 3, taking action, and 4, maintaining behaviors, fully engaged, can do this over time, about 20 to 25%. The point is, this is a tool that can be used in all medical groups in California to focus and stratify on patients with diabetes, cardiovascular disease, and other chronic illnesses. So this is in terms of behavior that they've studied in terms of what people engage in each of these 4 stages. So as you can see here, the level 4, it's a nice linear relationship almost throughout all these, with level 4 being able to do the most. Take their medications as recommended, going from 33% in the lowest level to 88% in the highly activated level. 13 to 58% knowing what their blood pressure should be. Monitor their blood pressure weekly. Again, 6 to 33, so you might say, well, gee, 33%, that's not too good. Yeah, that's right, even among the highly activated. And then keep a blood pressure diary. Well, that's just one tool. There's many other ways of doing that. But nonetheless, even with that, level 4 is higher. So activation underlies most of those health behaviors. Many of these are asking of people are only done by those in the highest level of activation. So the message is to focus on the more complex and difficult behaviors. so that they don't get discouraged, the least activated, and start with those most feasible for patients, which is, right, what really matters to you. Not what's the matter with you, but really matters to you. How do I figure that out? What do you want to do? And I'll come back to that. So here are the impacts now on outcomes, and even 2 years later. So Judy early on had done some cross-sectional work, but this one actually looks at outcomes 2 years later. And the dark blue are the level 4s, and the medium blue level 3s, and then the light blue level 2s. And these are the odds ratios. So basically, if they were 2.0s, 2 times the others. And you can see them here that on HDL, it looks like it's about 1.5 positive for those in the dark blue, triglycerides, not smoking, not obese, pap smears, mammograms. PHO9 is the depression scale, and then you have no ED visits and no hospitalizations. And they're all in favor and almost a nice gradient between level 2, 3, and 4. Again, these models control for a number of other potential explanations. And this was an article last year in Health Affairs if you want to dig into the details. So the findings indicate the importance of the patient role in outcomes and costs. As payments become more closely linked to outcomes, and I think Arnie or somebody mentioned this morning, in the macro, and you choose between the alternative payment model or the MIPS, physicians and their practice are going to be asked to begin to report on these patient-reported outcomes. And talk about how can that be done in a way that isn't so difficult currently. And so this is going to have some real implications in terms of payment as well, and therefore, if it's patient-reported outcomes, not just blood sugar levels and lipids and so on, you're going to have to focus much more on getting to know your patients and their idiosyncrasies and how to motivate them and how they can motivate each other. So they've been doing work at Fairview in the Twin Cities. Fairview is a pioneer, ACO, 98,000 or so patients. They studied the PAM scores from 2011 to predict outcomes in 2012, 13, and 14. And they saw an illness progression diagnosis of a new chronic disease 1 to 3 years later, and ambulatory care sensitive admissions. They looked at ED visits and preventable utilization as well. This is a very recent article in August, issue of Health Services Research. So here we go. So you can see here the odds ratios from the regression, again, predicting a new chronic condition 1 year later. So PAM level 1 are the least activated. Okay, everything else now is controlled for at baseline, health status, age, sex, etc. All that's taken into account. These are net effects. You can see it here. Much more likely, 1.2, 1.3, to have a new chronic condition 1 year later. If they're still pretty lowly activated, about 1.1, and then it begins to go down level 3 and level 4. Again, not markedly, but to some extent. Level 4 here is actually the reference group. So what does it do in terms of costly utilization that could have been prevented? This is the first time that the PAM's been examined in relationship to ambulatory care sensitive utilization. That's the 12 conditions, diabetes, asthma, and so forth, that if you're really getting good primary care or self-management, you should never be in that hospital bed, right? Okay, and there you see a little bit more dramatically, okay? So here, PAM4, you can see the results here, and the odds ratios for those that are less motivated, much more likely to be hospitalized with an ambulatory care sensitive condition. Why would less activated patients have more of these avoidable hospitalizations and ED visits? Well, this is sort of some interviews they did, and maybe just kind of thinking about it, less likely to recognize red flags. Okay, they're just not paying as much attention, they're not motivated. More likely to ignore symptoms. Less likely to know what to do to handle symptoms. Less likely to be socially engaged with neighbors or their family members or whatever. Most of these people, as you recognize in this category 1, are clinically depressed as well. Okay, that could be a common thing on this slide, accounting in part for all of these bullets you see here. So the implications is this is a part of the waste. This is a part of the waste. Okay, these are utilization that could have been prevented. It's not just happening in the high-risk population where much of the efforts are currently focused, but even among focusing in particular, we need to focus on the less activated patients, because that's a real opportunity to reduce costly and wasteful utilization. So we often think of waste in hospitals and so forth as inefficiencies and the door-to-balloon time taken out on warranty and complexity, absolutely. But think of it this way, is also waste when people end up in these facilities that really don't need to be there. So increases in activation are possible. If we want patients to take ownership, we have to make them part of the process. Listen, problem solve, collaborate. We just heard a wonderful example from Kaiser and Memorial Care, motivational interviewing, not one thing, a whole package of things they did, adding social workers, adding dietitians, et cetera, to help them gain the skills and confidence that these patients need. It represents a major paradigm shift from telling patients what to do, different than compliance, and there's a focus on developing confidence and skills and not just a transfer of information. So for these innovative delivery systems, you might want to think of PAM as a vital sign, okay? Just like blood pressure, et cetera, what their score is. It helps you tailor the coaching and support. So what Diane and Judy said this morning about what they're doing with these practice transformation grants, they're learning one size doesn't fit all. Those health coaches they're using are going to have to pay attention to this in terms of the specific patient, and it's going to have to be modified depending on those patients. So you use both a behavioral lens and a clinical lens to manage these patient populations. You can use it as an intermediate outcome of care and as a way to assess provider performance as well. This kind of brings it together here, low disease burden, high activation. If that's the group you're looking at, focus on healthy behaviors, provide online tools, and community supports. So the point is, this is the easy group. They're highly activated. They have very low risk diabetes. It's in control. Those are some of the things you might want to keep them that way. The right-hand cell up there, so it's high disease burden, but they're also very much activated. You want to really partner with them, leverage their activation, etc., provide online tools and community supports. Low disease burden, low activation, focus on increasing activation. You have time, because they're not real sick. Slow the risk, improve behaviors, coaching support. So that lower right hand, that's the cell 1, as it were, or level 1. You really need to work on developing those self-management skills, coaching support from trained medical assistants or others to augment the conventional clinical support in coaching to prepare for clinical visit coaching after the visit. This is the 24/7, all out, constant, day in and day out, managing and working with these patients. So it's about meeting patients where they are, improving that experience, increasing the likelihood they will do their part, improving efficiency, more targeted use of resources, and improving outcomes and reducing costs. The early evidence that you've seen suggests that. And one of my favorite memories in order to underscore some of these points is a story that some of you may be familiar with. Dr. Sobel, the Kaiser Permanente internist there, and he's done a lot of creative work in health behavior and so forth. He's now semi-retired. Tells this wonderful story a number of years ago of how a patient in him that was seeing him, I'll just call him John, I forget what his name is, or I'm sure it was disguised, came in to see Dr. Sobel. And Dr. Sobel was just really, didn't want to have anything more to do with him. And as far as Dr. Sobel was concerned, this was a visit he was going to fire the patient. And he started out saying, he says, John, you've been seeing me for 4 or 5 years now. You're still basically, you didn't use this term probably, but it was really strict. You're still a mess. You do nothing I say, et cetera. So I'm obviously not the doctor for you. You are depressed. You know, like I said, you're not going to the mental health visits, and so on. So this is the end, but I can make a referral, et cetera. And finally, Dr. Sobel gave one more try. He says, John, is there anything at all that really interests you in your life over the next couple months or so? And John kind of thought about it and said, well, you know, some of my high school friends are coming back to the area and they want me to go fly fishing with them. I used to be able to do that. That would be kind of interesting, maybe, again, if I could do that. Bingo. the light bulb goes off in Dr. Sobel's head, and he says, John, that's terrific. Are you serious? I said, yeah, I'd like to be able to do that. I know I can't. I can barely walk out of the office here. You know, I will help you do that. If you really want to do that, I will help you do that. Long story short, he did. He went fly fishing about 3 months later. So Dr. Sobel tells that story about, well, maybe you never give up, but it's really trying to turn that on with where the patient's at in their life journey that we have to get into. Okay, so that's what Judy Hibbard, and we'll tee up the next, that's what Judy was going to talk about. I was then going to come up and talk about doing a deep dive, given those results as background, some work that Hector and I are in the middle of. This is a Pete Corey grant that we're working on. We're working with 2 large accountable care organizations, healthcare partners, or I should say DaVita Healthcare Partners in Los Angeles, some of you know them well, and Advocate in Chicago. And what we're looking at is diabetes and cardiovascular patients over time. I'm going to present some of the cross-sectional results today. Over time, in terms of what they might do, it's a natural experiment, are doing in terms of activating patients and whether or not it makes any difference, not only in clinical outcomes, but in patient-reported outcomes as well. So that's where we're headed. Okay, this is our team here at Berkeley. Here today, you see Hector's here. Hattie's in the middle there. You see Hattie. Amanda's there. Somewhere she just left the room. Susan Ivy's here today, but she missed this photo. Brent missed this photo too. They're going to show data later. They're not sure they want their picture in here. But anyway, we have a larger team, as you can see, because we're working on a number of studies. But those are some of us at least. Okay, these are our funders. Always acknowledge your funders, right? Gordon and Betty Moore Foundation, the Patient-Centered Outcomes Research Institute. This is mostly what we'll present today. ARC, the Agency for Health Research and Quality, and Blue Shield of California Foundation. I've gone over the definition. It's the one Judy Hibbard and others have used. This is a recent report by Kevin Volt, who's an internist and economist, behavioral economist at Penn, and a colleague of his. Results of a recent Catalyst survey on patient engagement showed some early successes, but most of these initiatives have yet to be scaled up. So this is National Institute of Medicine, now National Academy of Medicine workshop a few years ago concluded prepared, engaged patients are a fundamental precursor to high quality, lower cost, and better health. And so we will see how that might be brought about. So these are the 2 organizations we're working with. Very briefly, one's a big multi-hospital system in Chicago. For about 12 years, they've been engaged in a clinical integration effort. They have an own medical group of about 300 plus physicians and several years experience with at-risk contracts on the private sector side, and I believe they also hold a Medicare contract now as well. DaVita, headquartered in Los Angeles, has a number of these owned and affiliated groups. They were an early Medicare shared savings ACO, and they hold some commercial at-risk contracts as well. So what we did, this was our sample selection. We're looking at 16 of these primary care practices, 8 from each ACO, and they've been selected from the top quartile and the lower quartile on a baseline measure of patient activation and engagement. We're taking sort of advantage of what they were doing anyway, a natural occurring experiment of sorts, and I'll show you that 39-item inventory, because you could use it if you want to use it as a tool. So we get their scores, we spread them out. There's a top quartile and the bottom. We randomly sample from the top, randomly sample from the bottom, because we want to kind of spread it out at the beginning looking at these practices. And that's a few differences overall between panel size visits, et cetera. You can see that Healthcare Partners has more Medicare patients than did Advocate at that time. So this is our central thesis, right? It makes sense that patients receiving their care from primary care teams with a more patient-centered culture, and I'll define that and measure it, with greater shared decision-making, better communication and coordination among team members. So we're looking under the hood of what's going on in these practices with a battery of organizational assessment instruments, and that they will have, therefore, better patient-reported outcomes. But we thought those relationships would be mediated by how activated their patients are in their care. So this is the baseline survey. I'm not going to read over all of it. We had this completed by the head of each primary care practice, and it was on a scale from all doctors do it to none of our doctors are doing this. So for example, number 7, we encourage relevant patients to participate in an employee health promotion program. Number 10, our clinicians, we just heard it, are trained in motivational interviewing techniques. They consistently use them. Here are some others. So number 17, patients can routinely provide information on their care and their health via a patient portal, not just access, etc. Telehealth's made available where it's needed, and so on, and a few others as well. So number 25, there exists an organized follow-up program to assist patients in managing their medications at home. Pharmacist-led medication management team, as we just heard. So we had all the baseline data on this, get the scores, we spread it out, and we randomly selected practices. We have re-administered this as well. We'll be looking at changes over time. So here are our patient-reported outcomes. These are what MACRA is going to require, more practices. These are the physical functioning ones. This is work that began 10, 15 years ago, has been validated in a number of studies as well. These are just some sample questions here about, does your health now limit you? Walking more than a mile, climbing stairs, lifting, carrying groceries, etc. Are you able to do the following? It varies from not at all to cannot do. Okay. Social function. I have problems trouble doing the following. All family activities I want to do, my usual work, getting together with friends. I have to limit the things I do for fun with others, etc. So we have a scale on that. Here's the patient-reported emotional outcomes over the last 2 weeks. This is not a good one to ask for anyone in this room. We would all flood this and be in the lowest category of activation. How often have you been bothered by the following problems? Feeling nervous, anxious, or on edge. Not being able to stop or control worry. Feeling down, depressed, or hopeless. Little interested in pleasure in doing things. I apologize. This is what it is. Okay, patient-centered culture. This is an important variable. We developed this from the Baldrige Award for Quality around meeting customer needs, and in this case, patient needs. It's 5 simple items. We're interested in the extent of your agreement or disagreement, etc., with each of the following. So the practice does a good job of assessing current patient needs and expectations. Patient complaints are studied to identify patterns and prevent the same problems from recurring. And we have 3 other questions like that. Coordination. A colleague of ours at Grindus, Judith, has developed this measure of coordination, relational coordination. It's 7 items. It takes about 15 seconds to complete by anybody. It has to do with the nurse, the doctor, whoever's a member of the care team. To what extent do we share goals? To what extent do we have common knowledge? To what extent are we focused on same problems? And then how accurately, frequently, etc. do we communicate with each other? So this you can do within the group and across groups. It's a measure of relational coordination. These were the people we were looking at and completed this instrument for us. Shared decision-making here. In the last 6 months, when I received care for my chronic condition, I was given choices about treatments to think about, etc. This is the Patient Assessment of Chronic Illness Care, called PASIC, developed by Group Health up in Seattle. It's been widely used in other studies, so we use that. Here's the PAM. I've gone through that. Okay, we control for age, sex, education, insurance status, English literacy, and disease burden. And here's what we found. I need to put these in probably things that are more graphic and will show these differences. But cutting to the quick, practices who have a greater patient-centered culture, the patients who see those practices have better physical and emotional health outcomes. They also have better social health outcomes. It was not statistically significant, but it was, as we say, in the right direction. But also, the better they evaluated the chronic illness care they received, the second bullet, that was also associated with all 3 better physical, social, and depression outcomes. But when we then introduce in the equation the PAM, it totally mediates that last bullet. Okay? It's accounted for by the more activated patients. patient-centered culture has its own separate direct effect. So part of the message here is if you're working to try to engage your doctors in terms of what they need to do, it's developing this patient-centered culture appears to be really quite important. But at the same time, you've got to work in terms of getting to know your patients and stratify them and getting to know who are the most activated patients and how you need to intervene in that relationship. So those are the bottom line. We're also now going to be looking at this over time as well. So Hector's taken the lead on the deep dive into what I've shown here, and rather than us getting up and down, I've chunked these a little bit in the interest of time because we've also learned a little bit what's behind what I've just shown you. So what we've done, we're now comparing the high and the low practices, and we've made site visits. We'll go through it here, data sources and samples. So as I said, we sampled the top and bottom here. So we had about 411 of the doctors and staff complete these assessment instruments on relational coordination, culture, and so forth. We had an 84% response rate. One of these ACOs had 94%. It's almost unbelievable. It won't look good in journals because they'll think we simulated or what we didn't. It's just that this one ACO said, you will do this. But basically, he said, you will do this. This is what we're about. You will complete this. We agreed to be a part of this study. And then we did about 48 interviews with primary care physician staff, et cetera. They're an hour long. And we did it May of 2015. We repeated it May of 2016 in Chicago and Los Angeles. We got to talk to these people. And then we did a survey. So we have data on about over 2,000 patients with diabetes or cardiovascular disease, 51% response rate. We've got second round data on this, and we had about 73% response rate. So very little attrition from those who responded the first time. We're analyzing that data as well. So, and then we have clinical data on blood pressure, sugar levels, and so forth. Also, kind of interesting, high and low here. So you can see how these high practices are doing more of these things here. Motivational interviewing, 8 of them doing it, only 2 of the low. Medication management, 8 versus 2. Family, getting the family involved, 7 versus 2. Health coaches, 6 versus 2. Here's some other stuff here. Peer-to-peer programs, right, for diabetes, 6 versus 0. So you can see that here. This now is from the interviews. So we had all kinds of interview. Our staff listened to these things. We code them up. We do integrated reliability of various forms. And what you see here, maybe look at the percents, is you see that in the high PAE group, comments about empowerment and self-management much more prevalent than in the interviews with people who were in the low PAE practices. Same thing for team meetings and communication. Same thing for quality improvement initiatives as well. These are statistically significant in yellow. Some of the others you see also, but they didn't reach a significance when we look at them. Okay, team structure differed in the high versus low. So let me put them both on there. In the high, they would make comments about, we know who the team is, it's bounded, we have a lot of interaction between our roles. In the low, they weren't so sure about who the team was. Well, there's follow-up calls, there's referrals, it's the doctor and the patient family. It was much looser. In the high PAE, the teams often work together to address a whole range of social issues. They arrange for transportation, financing support, social support, some of the social determinants issues, some of the things that practices can do, right, in terms of dealing with some of these problems. And in the low, only one person mentioned addressing these kinds of needs. One person. So here are some others. In the high, they mentioned low engagement only when we asked about that specifically. But they wouldn't keep raising it again with other quite different questions. But the low, right, often mentioned, oh, it's the patient. You know, we're doing these things, the patients just don't comply. The problem with the patients. Okay, they would raise it even when discussing other topics. They would come back to that. So here's a phrase from a doctor in a high group. I run the weight loss clinic here, and we really need to expand. We need to grow more, because one of the biggest factors that causes diabetes is obesity, and we need to address that. this is at the time of the interview, the 4450, it doesn't mean anything substantively. The nurse, everything that I do in the morning, the huddle, is to improve access right now. It's like a knife in my heart. And on the other hand, the doctor in the low group